Hi, I'm Dr. Sam Mann, and this is Beyond Conventional Medical Thinking. And we have a special guest today on the topic of back pain, which is a problem that is so widespread, and for which often we do not have adequate treatment. And I think Dr. Schechter offers some important perspectives on that, and we will hear from him presently. Dr. Schechter is a private practice physician in West Los Angeles, California. He met Dr. John Sarno as a patient and later became a research assistant with Dr. Sarno. He was the first medical student to take an interest in Dr. Sarno's work in tension myoneural syndrome, otherwise known as TMS, or neuroplastic symptoms. Dr. Schechter attended Princeton University, received his medical degree from NYU, residency at UCLA, Santa Monica, and he is an attending physician at Cedars-Sinai Medical Center. He has also taught at the USC, University of Southern California School of Medicine. He has written several books, including Think Away Your Pain, The Mind-Body Workbook, The Mind-Body Workbook for Teens, and The Lessons Dr. Sarno Taught Me. He has co-created an online program called The Mind-Body Healing Journey and co-authored The Mind-Body Workbook Volume 2, and also a diagnostic guide for psychophysiologic disorders. Welcome, Dr. Schechter.
Thank you very much. It's wonderful to be here, Dr. Mann, or I'll call you Sam.
Yes, thank you, David.
Yeah.
So the topic is back pain, which is a hugely prevalent problem. And there are many causes for it, medical and non-medical, and the mind-body connection. In your estimation, what percentage of back pain do you think is mind-body as opposed to anatomic? And what do you think?
Well, I think we have to make a distinction between acute back pain and chronic back pain. So acute is defined as the first typically 6 weeks of pain. Subacute is usually 6 weeks to 3 months, although some people stretch it to 6 months. Anything beyond 3 to 6 months is considered chronic back pain. So in acute back pain, many of these episodes are muscular fascia. Sometimes it's something more structural, like a disc extrusion pushing on a nerve. Those are less common, but they can cause quite severe pain down the leg. And the good news is that 95% of these acute pain episodes resolve completely within 6 weeks. Many of them resolve within a week or 2 weeks or 3 weeks. It turns out not to matter a lot what you do during those first 3 to 6 weeks, according to published research. It is important to get moving rather than to be overly restrictive on one's activities. And this is well documented in publications. In the acute phase, some of these episodes are in fact triggered by emotions, triggered by stress, and that can be manifested by a person who has done the same activity 100 times and does that activity, for example, lifting a child the 101st time, and boy, their back goes into spasm. But when you talk to them or interview them, although they're having a real physical spasm in the back, it turns out in some cases that the day before they got fired, or they had a big fight with their wife that day, or they had some other trauma that reactivated an emotional network. And so even some of the acute cases, perhaps 20 to 30% have a significant emotional element. It might even be higher than that. But it doesn't matter what you do because the vast majority of them get better. Now, when you're talking about chronic pain, which is what I've specialized in over the last 30 plus years, I've treated over 4,500 patients with chronic pain with this approach, many of them back pain, some other types of pain like pelvic pain and neck pain, etc. But I would say over 70% of chronic pain seems to be mind-body or psychophysiologic or neuroplastic, as we're calling it these days. And this is the most, and I want to diagnose people with that. And sometimes they come in hoping to be diagnosed with that. And occasionally I have to tell them it's not that. Why do I want to diagnose them with that? Because we actually have an effective treatment strategy and treatment approach to chronic pain that is neuroplastic. We have an effective program of education, psychology, activity, and other advice, and people who can help deal with that, including therapists, coaches, etc. So it's common. It is not necessarily yet conventional medical thinking, which is why we're on this podcast talking about it. It should be conventional medical thinking because I feel like it's a medical diagnosis. Um, Even if your pain is not due to a structural problem, that's a medical diagnosis. And the medical diagnosis that we've used for decades was tension myoneural syndrome, TMS, and we're now calling it neuroplastic symptoms. And even ICD 11, which is the next one coming up, the diagnostic codes for physicians, has something called, I believe, general pain, or something that's kind of a non-structural cause of pain. There are also ICD-10 diagnoses that we use as well. But I hope that answers the question, and I'll wrap it there.
Okay, and the question also is what degree of testing is required to rule out a anatomic or
Yeah.
physiologic cause unrelated before assuming. I mean,
Right. So, I mean, due diligence is important. My mentor, Dr. Sarno, mentioned that in several of his books, certainly taught it to me when I worked with him decades ago. And it really depends on the patient. If you have a 30-year-old with back pain and several of these notable tender points that we look for in the diagnosis and a clear psychosocial history, you may not need to do any imaging or any diagnostic testing. If you have somebody who's got more complicated symptoms, maybe involves leg pain, if they're over 50, you definitely need an X-ray. And in many cases now with the technology, you need an MRI scan to be able to clearly make a distinguish between a structural problem versus a mind-body issue. And the key thing here is that many of my patients have already had MRI scans. It's sort of how they're reviewed and how they're diagnosed, because we know from MRI scans that they're too sensitive. They find too many things that are not actually the cause of pain. And we have many studies now, going back to the original Jensen study in the New England Journal of Medicine 30 years ago and going from there, which shows that asymptomatic people just picked off the street and offered some money to do an MRI scan as part of a research study will very commonly have bulging discs in the lumbar spine and cervical spine. And so making a clear diagnosis is not just reading an MRI report and saying, oh, you have a bulging disc. It's really understanding the symptoms, I look at the actual images. I have the training in that to look at that and to really say, is this structural issue, if there is one, does it have anything at all to do with the symptoms the patient is having, or is it a purely incidental finding that would be very common, as I mentioned, in asymptomatic patients, and was probably present in the same patient 6 months before or a year before or 2 years before when they didn't have any symptoms at all. So it takes a little bit of sophistication to do the due diligence work, but I certainly don't believe in making this a diagnosis without reviewing testing and without doing a careful physical exam as well.
right. And how open are patients to the diagnosis of a mind-body connection with this? And I guess with that, I'd be asking the patients that come to you, what percentage of them are coming specifically because they think it might be a mind-body disorder, but they don't understand how, or they're seeing you, they have back pain, they want help.
Right. So as my practice has evolved over the decades and as I become more well known with the books I've written and the articles I've published and all of that, I would say that I have two groups of people. I have probably 80% of the patients that see me with chronic pain know that this is an approach that I utilize, and they're curious to see if it could be appropriate for them. Or maybe they suspect it's the diagnosis, but they have doubts and they want those doubts addressed. Or as you said, maybe they just need a detailed treatment program once the diagnosis is confirmed. Part of the treatment program is, in fact, to confirm the diagnosis in front of them. And 20% of my patients or 30% are people who come to me incidentally as part of my work as a primary care physician or my work as a sports medicine physician. And then I'll say to them, hey, there's a different way to look at this. I see you've already done physical therapy. Maybe they've done chiropractic. Maybe they've done injections. Some of them have had surgery. There's a different way of looking at this. And let me explain to you what that is and why I think it might be applicable in your case. And I would say, about 60 to 70% are at least willing to look at it further, which might include a website or reading an article or reading a book. Some of them just completely shut down at that point and say, no, that's not what I'm looking for. I'd like you to work with me as you would with an athlete or as a sports medicine injury. And I have ways of navigating that path too. Sometimes I say to people I train, to medical students or residents, I say you have to plant a seed, and sometimes that seed grows, but it typically takes a while for that seed to grow. And so sometimes planting that seed is important. To give you another interesting example of this, I've heard from many patients that they'll receive a book as a gift, maybe a Christmas gift, maybe a gift of a birthday gift. And the book is one of Dr. Sarno's books, or now one of my books, one of the other books written in the field. And they'll initially scoff at it and put it on the bookshelf and kind of ignore it or put it in a box. But maybe 6 months or a year later, they have another episode of pain or they're still having pain. They pull the book out. But now something remarkable has happened because they're open to it. They read it with an open mind. And invariably, those people are calling my office Monday morning desperate for an appointment, even though they could have had one 6 months before had they called. And that group, of course, then becomes a group that would be open to this diagnosis. So I'm okay with skepticism, but I need a little bit of openness to help people with this approach because it is very much a collaborative approach. It's not what the physician does to you. It's more of what you do with the guidance of a physician.
Right. And any other particular types of pain that would make you suspect a mind-body connection? Because there's so
It's
many different
pain and
types
it's
of pain.
patterns of pain. But I mean, it could be anything from headaches, could be neck pain and back pain, could be abdominal pain or irritable bowel syndrome, could be pelvic pain, could be occasionally foot pain or knee pain, um, shoulder pain as well. There's lots of different types of pain, but it's the pattern of pain, right? It's people whose pain often waxes and wanes, although not always. Some people have it pretty constantly. It might be people who begin to notice that during periods of emotional tumult that the pain is worse. I've had people make that connection, and that prompts them to look into it further. It may be
Right.
people who have a more complicated childhood background emotionally, or a recent divorce, or recent financial stressors that I find the pattern may fit. Or it may be people whose pattern is very inconsistent, so they can walk 5 miles without pain, but they go up a flight of stairs, it hurts. Or if they'll say to me, it hurts after I lie in bed for 6 hours, but it doesn't hurt when I lift weights. There's things that kind of don't make sense. Or some people will say, every night at 8 o'clock, I have the pain. Well, that doesn't really make sense from a physiological standpoint, but it does make sense from a psychological standpoint. So patterns of pain and really almost any pain can have a mind-body element to it, or be neuroplastic symptoms.
hmm And do you think a majority of patients with this understanding can be helped?
The majority of patients who are open to it can definitely be helped. The challenge, and this is something that Dr. Sarno talked about, in his books and decades ago, is that people, only a certain percentage of the general population are immediately open to this idea. I think that percentage has gone up gradually. It may be higher in certain urban areas. It may be higher in California than it is in Pennsylvania. It's hard to say, but one does need a certain amount of openness to the idea that we have to go beyond conventional medical thinking to get to the solution to your problems. But
Right. It's analogous also. My specialty is hypertension, and most of hypertension is not a mind-body disorder. But in those who it is, um, it's very interesting because there's a low receptivity, and there's a way to talk with patients because otherwise they walk out and they, oh, he thought it's in my head
Right,
and get a
right. So
negative
that boy, that
reaction.
term in my head is worth discussing because it has come up so many times over the years. So one way that I address this now is I say to people that, everything at some level is in our head. If I give you an anesthetic and I put you to sleep, I don't give people anesthetics, but if you get an anesthetic and you're put to sleep, you don't feel anything because your brain is asleep. So everything all your responses, all your nervous system responses are in a sense in your head. They're in your brain and your nervous system. And part of your brain and part of your nervous system is your mind and your emotions. So in that sense, everything's in your head. But no, it's real symptoms. So I'll say to them, your pain is real. The question is, what's the best path to getting rid of your pain? And is that path more from the bottom up, which is what most of conventional medical treatment has been, whether it be physical therapy, injections, medications, acupuncture, it's bottom up, or is it top down? Is it working from your brain, your mind, your nervous system down to the body to heal? And that's where we're really going beyond the conventional.
Right. Do you think there's any way in the future that general internists, general doctors would be more receptive to these understandings?
I think they need to get training in it. I think need to get trained. The earlier, the better. Um, I mean, I have a vision where these concepts are taught in health education when you're in middle school or high school. Most states require a health education class, and yet it teaches you nutrition, maybe mentions exercise, mentions drug use, a few other things, sexuality, but it doesn't really discuss mind-body connection. I've written a mini curriculum for that and worked with school teachers and child psychologists on this. I'd love to get this into middle schools and high schools. If any principals are listening to this podcast, contact me and we can talk about that.
Hmm.
I would obviously like to get this into medical school curriculums. There's so many things taught in medical school, some of which is extremely important, some of which is less important, some of which may be uh, unimportant compared to the mind-body connection, compared to neuroplastic symptoms. So, and then in residency programs, both in primary care and specialty fields, people need to be taught this. Doctors tend to do what they've learned. It's the rare physician who can dramatically move away from the methods and approaches that they learned during their medical school and residency. So we really need to get to that level. But it's challenging for sure. It's been challenging for a long time.
Yeah. And to what extent do you think the mind-body connection is related either to the severity of the emotions or to how distressed the patient is? How strong is that connection? Or can it be emotions that, yeah, they're aware of, but it doesn't bother them very much? Um, is there a trend one
Yes,
way?
it can be both. It can be both. And they just to go back to childhood, which is an important developmental phase in our lives. Our early childhood, infancy, obviously we don't have a lot of memories of those, but we may have heard from others how the health of our mother, let's say, mental health, physical health, our fathers, siblings, and then we begin to have memories after that we're able to relate. Adverse childhood experiences, ACEs, has been investigated in research over the last 20 years plus, and it has a huge impact, many times with a delayed effect on our health, risk for a lot of diseases, including diabetes, I believe hypertension, and chronic pain. So some of these things can happen a long time ago and be subtle. Other times things are more dramatic. I mean, I have the occasional patient who has severe depression or severe anxiety. Many of my patients with chronic pain are highly functional and are able to work. Some are not, but many of them are able to work, some in very high capacities. And despite that, there are emotional issues that haven't been processed, haven't been dealt with. They may not have any awareness of them at all. And but that's what we have to unravel. And sometimes we're able to unravel that with an office visit. I know you've mentioned to me about the detailed interview you do at your first visit with certain patients. I do a very detailed interview with chronic pain patients. I'm able to find out quite a bit, but it's one session. And then I find that journaling, I find, is another way to help people get at some of the emotional issues, including issues they may not be aware of initially. I tell them, you may not journal about the key issue on day one, but you may journal about it on day 17. And just things just start flowing out. And that may be the unconscious starting to get to the surface on day 17 or day 22 of your journaling. I mention these days because I have a 30-day workbook, but it really doesn't matter how long they've been journaling. It could come out at one point or another. Psychotherapy, obviously, is another form of getting at some of these emotional issues. I work with psychologists and social workers and other people trained in the mental health area. And many of them will relate to me that, they have a 50-minute session, but the key issues always come out minute 47, minute 48, minute 49, because it seems like people are sort of dealing at one level superficially, and then maybe at the end, they begin to finally get into a point where they can approach deeper issues. Makes the ending at 50 minutes sometimes challenging for the therapist, but of course, those issues can then be resurfaced the next session. And so sometimes they're obvious and sometimes they're not obvious. And sometimes we initially think it's one thing, but it turns out to be something else that is the emotional driver. And Dr. Sarno talked about acknowledging the emotions being very important, that you don't have to solve them. But I find sometimes you do have to solve them and sometimes you don't. So if somebody's in an extremely unhappy marriage, it may be that they can work to communicate better and improve the marriage, and that can help with their symptoms. Other times, maybe they need to leave the marriage or leave the job. I'm not telling people to get divorced on this podcast, or leave the job or find a new career. Or again, it may just be more introspection and understanding and processing of feelings.
Right. And which of your books or workbooks do you recommend, or does it depend, a certain book for a certain type of problem that patients, and particularly not everybody can come to you? Are there any
Yeah.
that they can benefit from just from going through the exercises in your book?
Yeah, patients have benefited and written me, even those who haven't seen me. But I take a very individualized approach. Over the years, I've written up a two-sided list of books and other things to do. It's like a menu in a restaurant. And your book is listed on it as well for hypertension. Although again, you mentioned that most of hypertension is not psychophysiologic. But in any event, I will circle typically a book or two or three for people to read. If they haven't read any at all, or if they have read them, I'll check them off and then maybe suggest one that they haven't read. I recommend journaling, which they can do in a $2 notebook from Staples, or the workbook that I have. I have two of them now, which gives them guidance, gives them a guided journal, gives them prompts to answer, which often makes it easier to journal. If they're dealing with gastrointestinal symptoms, I may recommend Dr. Clark's book. If they've had prior back surgery, I may recommend Dr. Hanscom's books. These are all listed on my bibliography. I believe they're on my website as well, and they're certainly individualized to patients. There are podcasts, and maybe I'll add this podcast to the list, but there are podcasts that I've done that I think are very informative that are on this list. I may circle that. I may indicate an app. There's the app called Curable. There's other apps now that have come out in this area. So there's movies. All the Rage was made about Dr. Sarno's work by a documentarian in New York. And there have been a couple of other movies that have been made on TMS and related disorders. So I recommend a series of sort of take-home assignments if I see you in the office and make this diagnosis, because I believe that just hearing the diagnosis is not enough. Dr. Sarno would give evening seminars for patients. It's often harder in Los Angeles for people to drive to a seminar. I did those for a few years and then decided that a home program was a more effective way to do it, given traffic and other necessities and people wanting to get home to see their families or other things. So I have a very detailed home program for each person. I also try not to overwhelm people, because too much is not good either. Too much of a good thing in this case, too much self-study. I tell people you don't have to become a PhD in mind-body to get better, but you do have to understand how this applies to you and apply it in your daily life. And then I'll do a follow-up at 3 or 4 weeks and see what they've accomplished so far and decide what we need to do at that point. Sometimes it's further discussion with me, sometimes it's referral to a therapist or a coach, and I've done some group sessions at times. So there's different things that the follow-up might involve, but I do work in a team model for many of my patients.
Right. And it's interesting to me, somebody who has severe stress, and whether it's several different things or one or two very severe things, and the stress is not going to go away.
Mm.
What is the best? How do you manage it with psychotherapy or antidepressants? What would you do in that circumstance?
Well, first of all, I would try to understand the stress better. Is this somebody who has to do 6 more months to get their pension at the company and they're going to retire? People can often deal with a certain number of months as long as they know there's an end point to it. Other times I want to look at how they manage stress. So maybe I encourage them to do more physical activity. Exercise is a great stress reliever. Maybe they should meditate a little bit. So I want to understand what the stress is and maybe how they're coping with it at that point. Um, Sometimes, there's stress around us and there's how we respond to that stress. And people have different personalities. So sometimes it's easier to change ourselves than it is to change the world around us. So if we're a 9.5 out of 10 perfectionist on the perfectionist scale, sometimes it's easier for us to dial it down to 8 3/4, which doesn't make us a type B mellow surfer dude, but it does just kind of take a little bit of the edge off so that the stress you're experiencing from the outside doesn't manifest itself with as much psychological distress, maybe as much physical pain or other symptoms. So I talk about this dialing down phenomenon. And, there aren't dials as many as there used to be. We used to have dials on televisions and dials on radios and things. Aren't this, but people understand the concept, which is sometimes you can learn to be aware, more self-aware of how you respond to different situations that cause you stress. And just be a little, you don't have to be perfect and you don't have to be someone else. Just be a little bit less perfectionist, a little bit less goodist, a little bit less responsible. Highly responsible people tend to get these chronic pain issues. So just tuning it down a little bit can be helpful. Now, if people can't do that themselves, then certainly psychotherapy can be helpful with that. But it's really more about, the person that you can manage the most is yourself rather than others around you. We don't have a lot of control over that. We wish we had more, but we don't have much. We have more control over how we respond and how we approach things.
So that was a very interesting discussion, and it was so interesting that we are going to meet again and discuss our views, which somewhat coincide and somewhat differ. My background as a hypertension specialist, and Dr. Schechter as a back pain specialist. And in the next session, we're going to be discussing very interestingly the similarities and differences between our perspectives. So we'll see you then.